Our final presentation for this session will be by Teresa Grund, who will be talking about a coordinated care model and engaging pharmacists in suicide prevention. So, Teresa, welcome. Thank you for coming to do this presentation, and the floor is yours.
Thank you. Good morning or good afternoon. I think we're almost in the afternoon now. First, I would like to express our gratitude and appreciation for the Lakota, Anishinaabe ancestral lands on which our program resides, and to the relatives who have been working and living on this land from the time immemorial. Thank you again for inviting me to speak today. I'm Lieutenant Commander Teresa Grund. I'm a board certified psychiatric pharmacist at the Red Lake Indian Health Service in Red Lake, Minnesota. And I practice as an advanced practice clinical pharmacist in a behavioral health medication management clinic here in Red Lake. So next slide, please. Good, thank you. As mentioned in many of the previous presentations, Indigenous communities know that culture is prevention. Asking how we can incorporate culture into prevention initiatives should be the first step in program development. As an Indian Health Service pharmacist and a commissioned Corps officer, I have had the privilege to learn from my patients and my coworkers the importance and positive impact culture has on the community members' physical and mental health. Next slide, please. As an IHS pharmacist, I have also had the opportunity to practice in a healthcare system that truly embraces the practice of an interdisciplinary team approach to healthcare. As many of our facilities are in remote areas of the nation, this creates a lack of access to care for these communities. Pharmacists are frequently employed in team-based approaches, allowing us to practice to the full extent of our license. One way this can be accomplished is through a collaborative practice agreement. Collaborative practice agreements enable credentialed and privileged pharmacy staff to be provider extenders, enabling pharmacists to have prescriptive authority for medications, monitoring for specific disease states. Providers can refer patients to our pharmacy primary practice clinic for the management of diabetes, hypertension, anticoagulation, and to our specialty clinics for hepatitis C, pain management, substance use disorders, and behavioral health. This access to care allows patients to be seen more frequently for closer monitoring and improved health outcomes. These visits are billable through CMS and some other third-party payer sources, which means these types of pharmacy clinics can be financially self-sustaining. Pictured here is myself and one of my care teams. This is our prenatal substance use care team, Dr. Carrie Josephson, and our recovery care coordinator, Nikki Larson. So next slide, please. So as mentioned in the previous slide, the access to care issues included shortages in mental health professionals across the nation as well. And as most of us working in the field of behavioral health know, COVID has increased the need for behavioral health services and additionally decreased the number of service providers and facilities available. In rural Minnesota, the reduction in access to behavioral health services prompted a collaboration with the University of Minnesota to train pharmacists to provide behavioral health medication management. Next slide, please. During a gap analysis of the barriers that pharmacists would perceive related to screening for depression, we discovered that pharmacists were not comfortable or trained with handling suicidal ideation that may be elucidated when doing these types of depression screenings. Knowing that a screening for untreated depression is an upstream approach to reducing suicidality, it was the impetus for an initiative development to engage pharmacists in suicide assessments. and started with me becoming a question, persuade, refer instructor and developing a training program for Red Lake pharmacy staff. So in 2018, all of our pharmacy staff in Red Lake was trained in PHQ2, PHQ9, and question, persuade, refer. So let's just take a minute to discuss question, persuade, refer. It is QPR is a gatekeeper training intended for anyone, medical or lay person, to feel less apprehensive when talking with someone who may be experiencing suicidal thoughts. For pharmacy, this QPR training ticked all of the boxes. It was easy to train, it was cost effective, and it could be applicable in any setting. Meaning that if you are a one-person pharmacy staff or a two-person pharmacy staff, QPR allowed you to do a quick assessment and referral, and that therefore you could do that in a very small setting in a very rural community. To this end, I became a certified QPR instructor. Next slide, please. So what is QPR? Question, persuade, refer is the equivalent to CPR. It is emergency medical intervention. And as pharmacists, as healthcare providers, many of us understood CPR and the use of it in a cardiac crisis. And so that resonated with my colleagues that not only should we be trained in CPR for cardiac crisis, we should also be trained in QPR for a mental health crisis. Next slide, please. So this is some of the data that came from this training. We trained our staff in QPR and in using the validated screening tools like PHQ9s and PHQ2s, and enabled pharmacists to be comfortable to screen every patient seen in our pharmacy at every visit. This became the standard of routine care and practice in our clinics. And as you can see, we dramatically increased the number of documented, next slide, please. So as you can see, we dramatically increased the number of documented PHQ2s and PHQ9s following the staff training on screening tools and assessments. You can also see that once again, COVID happened, and as the pandemic hit, more and more visits were telehealth and screenings declined. We are starting to see an uptick in that again, so we hope that those numbers go back up as the pandemic lessens and the effects of that lessens. Additionally, with this kind of positive outcome in a pilot, we can see that the goal for us was to scale up this model to our other pharmacy departments, other pharmacy staff in other regions, and across IHS facilities across the nation. So next slide, please. So in order to do that, I developed a toolkit. And a toolkit was a way to train pharmacists regardless of their roles or duties, to help them be comfortable in asking about depression, which may lead to identifying suicidal thoughts. This toolkit contained the PHQ2 and 9 screening forms, online trainings for PHQ2 and 9 assessing, training for question, persuade, refer. It also additionally contained training for the Columbia Suicide Severity Scale training and a template for a resource sheet. And this was so that we could identify the community members, the tribal programs that were able to help these patients, so that we had good referral sources, so that we knew what the patient needed to have access to those services, what we needed to provide to the referral services, so that the patient could quickly and effectively get in for care. And this enabled the pharmacy staffs to know what was the next step, where they could go and what they could do for the patients. We also included talking point referral for the referrals, so that we knew what questions to ask them and how to access their resources. Additionally, it contained a systematic hierarchy for suicide screening, and we'll talk about this in the next slide a bit more. It contained basics of sound safety planning and a trauma-informed care video. So next slide, please. So one of the toolkit items, as I mentioned before, included a systematic hierarchy for suicide screenings. And those of you who have worked in the behavioral health field may see this as an unnecessary or even obvious step. But as pharmacists, we thrive on guidelines and algorithms and step care approaches. This visual was my way of helping my fellow pharmacists to see that this was something they could do in a stepwise fashion. And as you can see, it is necessary to have some type of gatekeeper training first to ensure that pharmacy staff were comfortable with screening results that may indicate a patient is having suicidal thoughts. As many staff shied away from asking these questions or using these screening tools because they did not know what to do for patients that were having suicidal ideation. Next slide, please. So because the Red Lake pilot had positive outcomes, the next step was to promote the toolkit. And I presented the Engaging Pharmacy and Suicide Assessment Program to any pharmacist group I could get to listen. I presented all over the nation to multiple pharmacy organizations. And one of my first objectives was to help my colleagues see that as pharmacists, that we are the most accessible and frequently visited healthcare provider. And we are perfectly positioned to provide this type of service. And that suicide prevention is everyone's business, including pharmacy. Another goal of presenting to my fellow pharmacists was to highlight that this was not an attempt to make pharmacists counselors or therapists or mental health professionals, but rather we were to serve as a conduit to help our patients access the appropriate resources available in our communities. Next slide, please. So one of the first things I would present during this presentation was the national data related to suicide. That there were over 45,000 deaths in America due to suicide each year. That for every one suicide completion, there were 25 suicide attempts. And that one of the other pieces of data that seemed to strike home was that about over 40% of the people who had attempted suicide had seen their provider in the 30 days prior to that suicide attempt. And as I stated before in the previous slide, because we're the most frequently visited and accessible healthcare provider, how many of those same patients have also seen their pharmacist in the previous 30 days prior to that suicide attempt? Next slide, please. One of the other things in trying to engage my colleagues was to acknowledge the barriers to pharmacists in particular, to help them feel competent and to screen patients for mental wellness. We often heard things like, I'm not trained for this. What do I do if they are thinking of suicide? The other questions we would get were, there are tons of screenings. Which ones do I use? And I really don't have time to sort through all of the different screenings to decide which to use for our facility or which to use in our pharmacy. And understanding these barriers is truly the key to overcoming their fears. And the last barrier here listed is one of the ones most identified by pharmacists is that I don't want to make it worse. And here again, having some kind of gatekeeper training at baseline to really separate the myths from the truths regarding suicide was key in overcoming this barrier. So next slide, please. So developed a mental wellness assessment toolkit for pharmacists as a way to train pharmacists regardless of their roles or duties and help them be comfortable in asking the questions about depression and suicide. for pharmacy, it needed to absolutely be easy to use, readily accessible, using validated screenings, and to be cost effective. We don't have, many of us are short staffed, and we needed having time to send pharmacists to a 2 or 3 day training, or a pharmacy staff to a 2 or 3 training just was not an option. And those types of trainings could be costly, and again, were not an option for us. So this toolkit, the impact, next slide, please. So the impact of this grassroots initiative was that since 2018, I have been able to present to almost 3,000 pharmacists, pharmacy students, pharmacy technicians, pharmacy academia, and healthcare administrators. During these presentations, if time allowed, I would include the question, persuade, refer training in the presentation. And if not, I could offer to do the training virtually or in person following at a later date at whatever facility or pharmacy department that was needed. I can also say that I have had students that have reached out to me afterwards, and how do I become a QPR trainer? They would then go back to their colleges of pharmacy and train all of their fellow colleague students and academia there. In the Southwest, I've actually had a connection with Midwestern College of Pharmacy, and have over the last 3 years actually done virtually these trainings with students in academia in their facilities as well. So next slide, please. So what I've listed here are 3 papers whose authors' conclusions are that training programs such as the one described here for pharmacists can actually increase a pharmacist's self-efficacy and the positive perceptions and attitudes related to pharmacy staff and pharmacists actually having suicide screening be part of their routine practices. Next slide, please. So the pharmacy training pharmacists to play an active role in assessing mental wellness needed to establish a systematic hierarchy for suicide screening so that my pharmacy colleagues could engage in that and understand how that might fit into their routine practices. We needed to have validated screening tools, and as I mentioned before, it needed to be cost effective and easily accessible. And the creation of this toolkit actually provided all of those things. And based on all of that, I believe that pharmacists should assess for mental wellness. We are accessible, trusted, and with minimal training, we can be competent. As pharmacists are increasingly employed to improve access to care in non-traditional roles, it is imperative that we become comfortable in routinely screening for mental wellness. Using a step approach, as I described here, that includes training on validated screening tools and other resources, we can cost effectively train a pharmacist to assess for mental wellness and coordinate care through the referral process. So that is the end of my presentation. I would be happy to take any questions anyone has at this time.
Thank you for that excellent presentation. I want to direct the audience. There's in the chat function, there is a link that will take you to the website, and you can submit your questions there, and we'll be able to ask them. While we're waiting for questions to come in, I'd like to ask you, Teresa, a question that I've been asking each of the presenters, and it goes like this, that this workshop series is about how can we change the trajectory of Indigenous suicide. And there are, of course, many barriers, and you nicely in your presentation laid out a number of them that you had to address. If we were to turn the question on its head and become strengths-based for a second, what change could those of us in the audience, could we advocate for that would move the uptake of the coordinated care approach forward? What could you see happening that would be helpful?
I think one of the strengths would be, as I mentioned very early in the presentation, that care team approach, a less siloed approach. I think that that's probably, and it was mentioned in many of the other presentations that I heard this morning, that has been kind of a basis for all of them. But as you said, using those strengths of all of the pieces of the team, accessing all of those individuals and all of their strengths to come together as a team and approach it from a less siloed kind of perspective and a more of a team-based approach, I think is one of the things that we could use across the nation to help improve it, to improve the prevention.
I really am just struck by how that's really a connecting point through all the presentations today, is this fragmentation of our approach for the prevention of suicide right now, and your work in one important way really directly addresses this, and I think there's a continuity across every one of the presentations that this is an issue that faces us. There is a question that just came in. I'll read it to you and see what you think. The question is about pharmacists you work with, and the question is: did pharmacists resist this approach for addressing mental health as not part of their role? Did they see mental health as not part of medical health?
Great question. And as I said initially, there were many barriers to engaging pharmacists in this type of screening. And there are some concerns that pharmacy as a field has about engaging in depression screenings and then, as I said, what to do what happens if you do have a patient who has some suicidal thoughts. Addressing those barriers from the beginning and addressing our accessibility as pharmacists, that we are just so often the most frequent healthcare provider that our patients see. They trust us, they tell us things, they talk to us regularly, and we may already be hearing some of the indications that they're struggling, and that as healthcare providers, whether that be mental or physical healthcare, that we have the responsibility to address those needs for that patient. And just using that type of language to help them understand that it really is everybody's business. It's not siloed. It's not just mental health. It's just not just the mental health department's responsibility, that it is really truly everybody's business, started to have a conversation turn. You started to hear different conversations in groups, and it really was about attitude changes or changing hearts and minds. But also, I knew from my fellow colleagues, my fellow pharmacists, that they needed training. They needed to understand how to do it in a way that they felt comfortable. And this toolkit was one of the ways that helped them feel comfortable in it, and then that they could go forth and do. So I hope I answered the question.
Thank you. And it actually raised a follow-up question that I had. It seems like it's very critical for this approach to work for there to be a referral, a place you can assist the person to go to, a trusted source of help. And we know in many, particularly rural communities, but in many communities, there's a shortage of providers. How do you work with that in the model? And when you do training, is that part of the process to help pharmacists identify where the referral sources could be?
Yeah, absolutely. Two of the toolkit items were actually about identifying the referral sources, and then how to have conversations with those referral sources on how to help patients access that care. And so by doing that, we helped our recommendation was that you actually assign somebody to make calls or contact all of the referral sources in your community, and then make a list of all of them and how to contact them and who to call and what time they were open and if they needed an official referral and those kind of detailed things, so that when you sat with a patient who may be struggling, you were not hesitating. You had an answer. You had a way to help them. And that increased it increased pharmacists' comfortability, their confidence in being able to assist patients adequately in a way that was really beneficial to them.
Thank you. And there's just a question that came in that's really a follow-up directly to that. And it just asks if you could talk a little bit about how do pharmacists develop and create meaningful relationships with their parents or their patients and the community through this work that serves to reduce suicide through coordinated care. Like, how does that process work, and how have you seen it unfold?
I think one of the best ways that I think is by addressing the patient's goals first. And what happened in some of our clinics, what I can say anecdotally, especially here in Red Lake, was each one of the pharmacists I work with who did this training and do it now regularly, routinely, has a story of a patient who came into their XYZ clinic, anticoagulation, hypertension, diabetes. It really didn't matter. But during that visit, because they had a relationship and because they were listening to what that patient was telling them, they identified that patient was having thoughts of suicidality at that moment, and was able to help that patient get to the resources that they needed. But that having that patient therapeutic alliance where the patient's goals and listening to that patient rather than having our own kind of agenda, I need to do, only XYZ because this is what the appointment is about, really helps to undo that thought process that many of us have as pharmacists, is that I have to ask these questions, I have to tick off my boxes, but rather that to listen to the patient and what they're telling you, and then actually engage with that patient and what their concerns are for the day. I hope that answers that question.
Thank you. I really think it goes back to one of your slides that this is everyone's business. And it's a shared responsibility and actually a duty and a gift that we can give by responding appropriately. I want to close by thanking all of the panelists. I just thought these were excellent presentations. I learned so much, and I rarely am actually personally moved by every presentation in a conference in the way out here. I just was struck by the power and the love and the concern and the dedication of people doing work in this area. At this point, we move to a 35-minute break, and so the agenda is we will return at 2:15, that's Eastern time, and please do come back. The afternoon presentations all proved to be equally exciting, and I think we all should learn a lot. Okay, thank you again to all the presenters, and see you back in a little bit.